Someone said, go for it, Audra. So I think that's it. Hi, everybody. I'm Audra Moran, President and CEO of OCRA, and I'm happy to welcome you all to Understanding Risk and Prevention Strategies. I hope everybody's enjoying the conference so far, and I'm thrilled that we're joined this afternoon by our featured speaker, Dr. Gillian Hanley of the University of British Columbia. But before I formally introduce Dr. Hanley, I wanted to provide just a little background as to why we asked her to speak and why we think it's important for you, members of the community, to hear from her. Prevention is such an important topic for so many reasons. I know many people have concerns about possible risks for family members. And I know many of you also do a lot of work in your communities raising awareness about ovarian cancer. And we are so grateful for your help. We're trying to help focus messaging on what we know will actually save lives. So we hope you'll gain a deeper understanding today about what people can do to assess and potentially lower their risk and even prevent ovarian cancer from ever starting. As you heard in my opening address, and as well as in Dr. Alvarez Cord's presentation, symptom awareness is absolutely important to get the fastest diagnosis possible, but it's not enough to save lives. We can, though, absolutely make a difference through prevention awareness. We just need to expand our messages to include information about risk management and prevention, as well as symptom awareness and what to do if diagnosed. That's what we're doing at OCRA, and that's why we've invited Dr. Hanley to speak today. She's going to talk to us about the science of ovarian cancer prevention, and I hope you'll gain a deeper understanding of what we can all do to raise awareness and save lives. So now it's my pleasure to formally introduce Dr. Gillian Hanley. She is Associate Professor in the Department of Obstetrics and Gynaecology at the University of British Columbia. She's a Canada Research Chair in Population-Based Gynecologic and Perinatal Outcomes, a Canadian Institute Health Research New Investigator, a Michael Smith Foundation Scholar, and a Janet D. Cottrell Foundation Scholar. Her research focus combines her interest in women's health with her training in economics, health services research, and epidemiology to answer questions related to gynecologic cancer, primarily ovarian cancer prevention and survivorship, as well as healthy reproduction and pregnancy. So Dr. Hanley, I'm going to turn it over to you. And I just wanted to let everyone know if you have questions, just put them in the chat. And if we have time afterwards, we'll do some questions. Dr. Hanley?
Thank you. Thank you so much for the invitation. I'm very happy to be here and to talk about this subject, which is my favorite subject to talk about. So as Audra mentioned, I'm going to be discussing prevention primarily, and I'm going to take you on a little bit of a journey. And the reason that I put for the general population in my title is because you've probably heard quite a bit about prevention for people who are at high genetic risk for ovarian cancer. So people with BRCA mutations and other mutations that increase their risk. However, what I'm going to be talking to you today about is really focused on people who don't have a known genetic mutation that increases their risk for ovarian cancer. So about 80% of high-grade serous ovarian cancers occur in people that have no known genetic mutation that increases their risk. And we really didn't want to leave these people behind in the prevention journey. So the work I'm sharing today is really focused on that group of people, so people who do not have a genetic mutation. So what I'm going to go through today is I'm going to talk about preventing ovarian cancer in those with no known genetic mutation through opportunistic salpingo-oophorectomy, which is where we started this prevention journey in British Columbia. And we've learned some really important things with that work. And then I'm going to talk to you about where we're moving this work, which is using salpingo-oophorectomy to really try to reduce the incidence of ovarian cancer writ large. So how can we make sure that fewer people around the world get ovarian cancer in the future? What are we doing to try to get to a place where incidence, so the number of people getting ovarian cancer, really comes down? And all of this work was made possible when we began to understand ovarian cancer differently. So many of you are probably aware that ovarian cancer is not a single disease, but 5 different diseases. And they have different cells of origin. And so high-grade serous ovarian cancers, which represent 70% of all ovarian cancers and are the most lethal, are commonly originating in the fallopian tube and not on the ovarian surface, which is what we used to believe. And when the evidence started to get really convincing that the fallopian tube was likely the tissue of origin for most of these cancers, we realized that we really had a prevention opportunity finally, because the fallopian tube plays no known role post-childbearing. And so I also like to do a little bit of a refresher on the anatomy, because I think it's often been a really long time since many of us thought about exactly what many of our reproductive organs look like and the jobs that they do. And so this is just a cartoon here showing the uterus in the middle, and then the ovaries are these pink circles on the side. And these are the fallopian tubes outlined in white here. And really their job is just to move the egg from the ovary to the uterus. So once a person is no longer interested in having any future pregnancies, that tissue can be removed because it's not playing any other role. And so typically in the past, when we used to remove a uterus, which is called a hysterectomy, we would take just the uterus and we would leave behind the ovaries and the fallopian tubes. And it was done that way because there was no reason to think that we should also take the fallopian tubes. And of course, we want to leave the ovaries behind because they're playing a very important hormonal role. So the ovaries continue to produce hormones even after the onset of menopause. They are still doing hormone production. And so generally we want to leave those alone, particularly in premenopausal women. We want to leave those alone because we know that premenopausal removal of the ovaries increases risk for other conditions later in life, such as cardiovascular disease, osteoporosis, Parkinson's, etc. So we try to leave the ovaries behind as often as we can, but we were also leaving fallopian tubes behind. And when we began to, I've advanced my slides a little too much here. When we began to understand that the fallopian tube was the tissue of origin for most ovarian cancers, we realized that we could actually remove those tubes at the same time of a hysterectomy. And what this video has just shown you is instead of a tubal ligation. So when somebody requested tubal sterilization in the past, we would ligate the tubes. So we would just cauterize and make sure that the egg wasn't going to get through, so it would not be fertilized. But now we are recommending that the tubes be completely removed. And it's very important to remove that entire fimbriated end of the fallopian tube, because that end in particular seems to be where the cancers arise. And so in British Columbia, where I am and live and work, we were the first place in the world really to adopt a practice change. Back in September of 2010, the Ovarian Cancer Research Team, which I'm a member of, recommended that all BC gynecologists begin to remove fallopian tubes at the time of hysterectomy or instead of tubal ligation. And we started referring to this as opportunistic salpingectomy. And the reason we called it that is because we were simply taking advantage of an opportunity that was already there. So that patient was already undergoing a hysterectomy for another benign gynecologic condition. So we had an opportunity here to take those tubes out and prevent an ovarian cancer. And the same is true for patients seeking tubal sterilization. Rather than ligate and leave tubes behind, let's take the opportunity to just get that tissue out completely and reduce risk for ovarian cancer in that person. And the practice change here was really, really dramatic. So we made this recommendation in 2010, and you can see how rarely this was happening prior to the recommendation. So in 2008, 8% of patients were getting fallopian tubes removed at the time of hysterectomy, and that increased to 75% by 2019. And for sterilization, this was really not occurring at all at the time of sterilization prior to the recommendation, and now 82% of tubal sterilizations in our province are by opportunistic salpingectomy. So we saw a dramatic uptake, and really it was because the gynecologists were so willing to do anything that they could to prevent one case of ovarian cancer, because we all know that this is a disease that we don't want anyone to get. And they were really keen to try to get on board with a prevention strategy as soon as they possibly could. So we've done a lot of work researching this in British Columbia in the past 13 years. The first things that we needed to do was make sure that this was safe, that we were not increasing anybody's risk for any perioperative or postoperative complications. And we have done all of that research. So there's no increase in length of stay in hospital. There's no increase in hospital readmission or requiring a blood transfusion during surgery. That's even true when this occurs at the time of cesarean section. So even in a very engorged uterus, there is no increased risk for bleeding. There's no increased risk in minor complications that occur after surgery, including doctor's visits, OBGYN visits, visits for surgical infections or complications, any kind of imaging being needed to be ordered, additional lab testing, additional antibiotic use. There's none of that. There's a slight increase in filling a prescription analgesic, but this disappears completely by 1 month post-discharge. And we have found no evidence that this reduces the age of onset of menopause. So we've looked at time to initiation on hormone replacement therapy, as well as time to the first physician visit for a menopause-related concern. And there's no difference in people who have their fallopian tubes removed and those who do not at the time of their other surgery, so hysterectomy or tubal sterilization. And as I mentioned, we've now just completed, and it should be published soon, a large population-based study on doing this at the time of cesarean section, because that's a very clear opportunity when a person is delivering a baby and knows that they don't want to have any future pregnancies. That's a great time to get the tubes out, and it is very safe to do so at that time. But the big question was, does this work? Are we actually preventing ovarian cancers by doing this? And so we did a very large prospective study. So one of the things that's tricky about doing this research is that because ovarian cancer is rare, and because these surgeries occur when people are still very young, you need very, very big numbers to see anything. And so you can see here that we had 32,080 people who had a control surgery. So one of the surgeries that they would have had prior to the recommendation for opportunistic salpingectomy, which is just a hysterectomy alone or a tubal ligation. And we compared these with 25,889 people who had opportunistic salpingectomies. And we followed them up through to the end of 2017. And what we were asking was, are women who've undergone opportunistic salpingectomy less likely to get ovarian cancer than the people who had the control surgeries? And what we found was that if rates of serous ovarian cancers were rising at the same rate in the opportunistic salpingectomy group as they were in the control group, so if we saw the same numbers of serous cancers across the groups, we would have seen 5.3 cancers in our opportunistic salpingectomy group, and we actually saw 0. So not a single person in that 28,000, I can't remember the exact number off the top of my head now, not a single person developed an ovarian cancer by the end of our follow-up. And given the age and amount of follow-up time, we would have expected to have seen 5.3. So this was significantly fewer cancers than we were expecting that we would see in this group. So we asked ourselves, could this be confounded? And that's a fancy word that researchers use to mean explained by something else other than the thing you think is explaining it. And so to look at that, we looked at differences in risk and protective factors for ovarian cancer across the two groups to say, is there an indication that the people who had opportunistic salpingectomy were somehow just less likely to get ovarian cancer? There were other things that might explain why we saw no ovarian cancers in that group other than the opportunistic salpingectomy. And what we saw was that the opportunistic salpingectomy group was of higher average age, which would increase the ovarian cancer risk in that group. They had had fewer live births, which again would increase the risk, as number of live births reduces risk for ovarian cancer. They had had fewer pregnancies, so even incomplete pregnancies are protective against ovarian cancer. So again, that would increase the ovarian cancer risk in that group. And they had more endometriosis, which again increases the risk for ovarian cancer, not high-grade serous ovarian cancer, but endometriosis slightly increases the risk for endometrioid and clear cell ovarian cancers. And this group did have more of that. So all of the risk and protective factors that we saw differences in across these groups would actually suggest that the opportunistic salpingectomy group should have had more ovarian cancers, not less. So then we wondered if maybe there was something different in these groups that could explain this that we just couldn't see or measure in our data. So we thought maybe there's something about these people that just makes them less likely to get cancer, and we can't see it in our data. So to answer that, we did the exact same analysis, but we did it with breast cancer. And what we saw was that we would have expected to see 22.1 breast cancers in our opportunistic salpingectomy group, and we saw 23, so almost identical. And the same is true for colorectal cancer. So we would have expected to see 9.4 colorectal cancers in the salpingectomy group, and we observed 8. So what this really did was give us a lot of confidence that that difference between the expected and the observed cancers in the opportunistic salpingectomy group was actually the effect of the salpingectomy itself. So the reason that there were 0 cancers in that group is because those tubes had come out. So we feel quite confident that the opportunistic salpingectomy is what decreased risk for serous ovarian cancer in that group. And that fits with what we know about the science regarding the fallopian tube being the tissue of origin for most serous ovarian cancers. So in summary, what we know about opportunistic salpingectomy from BC is that it is very safe, and that people who have had opportunistic salpingectomy appear to be at quite dramatically reduced risk for serous ovarian cancers. And so from this point, hopefully I've convinced you that opportunistic salpingectomy is a great way to decrease risk for ovarian cancer. And so now you might be wondering, what can we do? Can we use this in a way to meaningfully reduce the number of people who get ovarian cancer? And that is what I spend all of my time wondering as well. And so a few of the ways that we are trying to do that now is that we need to obviously remove more fallopian tubes. So we need to reach a larger proportion of people. And there's a few ways that we can do that. And one is to increase uptake at gynae surgeries. So we're still not at 100%. We're at very high rates in British Columbia, but there are other parts of even Canada and other parts of the developed world where rates are not as high as 80%, and we would like them to be. So we've been doing a lot of work to promote opportunistic salpingectomy by talking to OBGYNs and by talking to the general public, by talking to people such as yourselves, to get the message out, to talk to their family members, to talk to, if they hear of somebody they know who's undergoing a pelvic surgery, to say, hey, chat with your surgeon about whether they might remove your fallopian tubes during that surgery. We are also working to promote opportunistic salpingectomy for sterilization. So what this graph is showing you on the right-hand side of the screen is that the number of gynecologic surgeries where we could perform OS is decreasing over time. And these are BC numbers because I have BC data, but this is true all over. So we're doing fewer hysterectomies, and that is a good thing. We have minimally invasive approaches to deal with a lot of benign gynecologic disease that used to result in a hysterectomy. So we have other ways to treat those conditions, and that's good. We don't want to change that. But tubal sterilization is also really falling out of favor in terms of a choice for contraception. And so what we're doing is trying to talk to GPs about just including that message that opportunistic salpingectomy is an incredibly effective form of contraception and comes with an important ovarian cancer risk reduction as well. So we just want GPs to include that in their messaging around contraception counseling, because they do the vast majority of contraception counseling, so that people are aware when they're making that decision that tubal sterilization comes with this benefit of really dramatically reducing their risk for ovarian cancer. But we're not sure that we'll change the tide of tubal sterilization falling out of favor. You know, there are great IUDs that a lot of people are on now, and people really love them. So we'll see, but we do want to get the message out. But if we can't increase the rates of tubal sterilization, we can also increase opportunities to perform opportunistic salpingectomy. So right now, the opportunities are really largely confined to gynecologic surgeries, and it certainly does not need to be that way. So right now, we have a clinical trial that's up and running and recruiting here in BC, doing opportunistic salpingectomy during colorectal surgery. And this is a clinical trial that I'm running with Dr. Carl Brown, who's an academic colorectal surgeon, and Dr. Heather Stewart, who is a general surgeon. And we need our colorectal surgery colleagues and our general surgery colleagues to come on board. And there are so many of them who are incredibly keen to do this, and they totally get the value. And so Dr. Brown and his team, his colorectal surgery team, have been doing opportunistic salpingectomies as part of this trial. And we tried to make this trial as real world as we could. And it's not randomized. We're allowing patients to self-select. And part of the reason that we did that is because we really wanted to understand how many patients would choose opportunistic salpingectomy when it was offered to them. And then when patients decline it, we ask questions about sort of what are your hesitations, so that we can address that in the future with very clear messaging. And so the inclusion criteria here is just to be of female biological sex undergoing colorectal surgery, so very open and broad. And exclusion criteria is just that you've previously had your fallopian tubes removed, that you have possibly a desire for future pregnancy. You have to be very, very clear that you do not want to become pregnant in the future to be included. And then if there's excessive pelvic scarring, that would suggest that it may be unsafe. And so we've consented now 53 patients at this point, and 53 have had surgery. 42 of those chose opportunistic salpingectomy. So overwhelmingly, when people are counseled and given this option, they make that choice. They decide they do want their fallopian tubes out for the ovarian cancer risk reduction. We've had 32 surgeries at this point. So yeah, not 53 have all had surgery. 32 surgeries where successfully both fallopian tubes have been removed. So there was 4 cases where there were severe adhesions, so we could not remove. 3 where tubes were not accessible. 1 person only had 1 fallopian tube, and 2 people did not have fallopian tubes. So it can be very hard to know if you still have your fallopian tubes if you've had a previous surgery. It wasn't always very clearly communicated in the past. So we do find that sometimes there's a bit of confusion around who still has tubes and who doesn't. And the preliminary outcomes during this trial have been really great. So we haven't done very many of the control surgeries yet because so few people have chosen the control group. And obviously we need to compare the salpingectomy group to the control group, but we've only had 1 perioperative complication so far. It takes only 5 additional minutes in the operating room, so very, very little extra time. There's only been 2 patients who have required an additional port, which is just another hole for the laparoscopic surgery. And there's been 4 patients who required an additional instrument, and it was just a ligature, which is a very small, not major thing. And we're not the only people thinking this way. So there are many people in general surgery and urology who are really engaged and wanting to expand to provide salpingectomy during those surgeries. And this article here in JAMA, Salpingectomy and Ovarian Cancer Prevention, is written by Rebecca Stone from Johns Hopkins, who's been very, very keen to expand opportunistic salpingectomy beyond gynae surgeries, and they've made a lot of strides there as well. So this is great, because if we do this, we're going to reach so many more women and remove so many more fallopian tubes that we can hopefully make a bigger difference in terms of incidence of ovarian cancer. But the next really important thing that we're thinking about is not just removing as many fallopian tubes as possible, or we want to do that, and we're trying to do that, as I've just explained, but we also want to start thinking about removing the right fallopian tubes. So targeting patients who are at higher than average risk for ovarian cancer, despite not having a genetic mutation. So again, we're not talking about the high-risk people who have BRCA or BRIP1 or any of those mutations. We're not talking about those people. We're talking about people who are at higher than average risk without a known genetic mutation. And we know now, this is a slide I borrowed from a colleague of mine who's done a lot of work in this area. Her name is Dr. Lee Pierce. We know a lot about the risk and preventive factors for ovarian cancer, and we actually have some very good risk prediction algorithms. And one of them has been approved already for use in a clinical setting, and it's called CanRisk. And it basically combines some or all of the risk and preventive factors that you see on the screen. So the risk factors are things that increase your risk for ovarian cancer. And the number of arrows is sort of how important that risk factor is in terms of increasing your risk for ovarian cancer. So we know that people who have a first family history of ovarian cancer are at increased risk. We know that endometriosis increases your risk, particularly for endometrioid and clear cell, and not so much for high-grade serous. There are some common but low penetrance genetic variants that are SNPs that can be easily measured through saliva. Overweight or obese, higher height, menopausal estrogen therapy use. Preventive factors, combined oral contraceptive use. So birth control pills are very protective. So 10 plus years of birth control pill use dramatically reduces your risk for ovarian cancer. Same with Depo-Provera. Tubal ligation has been shown to decrease your risk, again, likely through the same mechanism that salpingectomy reduces your risk, but of course, removing the tube entirely is considerably more protective than just ligating the tube. Parity, which is the number of children that you have, breastfeeding. So if you've breastfed each of those children for a year or more, that's very protective. And then age at last pregnancy, incomplete pregnancy, and aspirin use are some other factors here that can be used to understand a person's lifetime risk for ovarian cancer. And when you do that, you can get sort of this picture where each of these little rows here is an individual. So this is a very large study. And you can plot them according to their risk, lifetime risk for ovarian cancer. And you can see that you get a lot of people who are not at very high risk. So a lot of people have a pretty low likelihood of developing ovarian cancer from now until the end of their lifetime. But you see that there's this other group of people here where these people, we should really start to think about offering them a risk-reducing salpingectomy. Because if we remove their fallopian tubes, we're more likely to prevent an ovarian cancer in somebody at this end of the risk distribution than we are in somebody down here. And when we're doing salpingectomy opportunistically, we're just picking anybody who comes along, right? So we're doing some down here, we're doing some down here, and we're probably doing some in here. But we don't know because we're just doing it because we have the opportunity. And what we're now thinking is that we want to take it to the next step, which is to do it in a way where we are trying to target people who are most likely to benefit from it. Because when we do that, we'll also prevent more ovarian cancers because we're targeting the prevention to the people who are actually at higher than average risk. And there's been work done from colleagues, particularly Dr. Manchanda in the UK, that has suggested that above 5% lifetime risk, we should be actually offering risk-reducing salpingo-oophorectomy, so removing ovaries in those people as well, at least until we have results from the TUBA-WISP trials, which are looking at whether or not salpingectomy followed by delayed oophorectomy is as effective for risk prevention in higher risk people. So, we're all waiting for results from those trials, but until then, the consensus is probably above 5% lifetime risk. We would want to do a risk-reducing salpingo-oophorectomy. And I know these lifetime risks sound very small often. People think, wow, that's a really big thing to do for a 5% lifetime risk. But, when you do all of the modeling and you look at survival, it really does make sense. And so, one of the things that a colleague of mine says is, risk-reducing bilateral salpingo-oophorectomy reduces all-cause mortality by 70% in the BRCA population. There is very little in medicine that reduces all-cause mortality by 70%. So, these are very effective prevention approaches. And while these lifetime risks don't seem very high, they are high enough to warrant acting upon. And so what we're doing now is we're really just at the beginning stages of this work. So we really want to hear from people about what they think about it, because, you can't just push ahead in medicine without talking to people and understanding what is acceptable to them, what they think is a priority. We want to hear from people about how they would feel about being offered risk-reducing salpingectomy. So we're surveying 200 people. We've almost recruited all of those people right now. And we're asking them how to think about this and to consider it and tell us their thoughts around whether this is something they would ever consider, and what lifetime risk they think they would consider it at, and what are they concerned about. Just tell us what you think. And at the same time, we're asking about their risk and prevention factors, because then we're going to choose people from within that group to actually do this with. So we're going to get their lifetime risk. We're going to take a saliva sample. We'll get their polygenic risk score. We're going to calculate their lifetime risk for ovarian cancer. And then we're going to talk to them again about risk-reducing salpingectomy and see if that changed how they thought about it in any way, knowing their own personal lifetime risk. And then, of course, we have to talk to all the OBGYNs about this as well, because they would be the people doing the surgeries. So that's sort of where we're at with that research agenda at the moment. So in summary, I hope I convinced you that opportunistic salpingectomy is safe and effective to reduce serous ovarian cancers, that we need to expand opportunities to perform opportunistic salpingectomies. And I hope that within the next 10 years, we'll be at a point where salpingectomy will be offered to all people with fallopian tubes having a pelvic surgery. Not in an acute surgery, because you need time to consider, but anybody having a non-acute pelvic surgery should be offered the opportunity to have their fallopian tubes removed at the same time. And we're beginning to consider and to move forward with targeted risk-reducing salpingectomy for people who are at higher than average lifetime risk, despite not having a known genetic mutation. So thank you again to OCRA for the invitation to speak, and of course to many, many people who are involved in the research that I shared with you today. This is truly a team effort, and then many funding organizations as well who have provided funding for this research.
Thank you, Gillian. Your study was amazing. I mean, I think everybody should know it's really a groundbreaking study, and really impressive. So first of all, thank you, and thank you for sharing your results. We're taking questions, so if anyone has a question, just pop it in the chat. I see one. How common is this procedure currently in the US, and why isn't this happening more widely already?
So it is happening quite regularly in the US at hysterectomy. The uptake in the US, actually, we were a little bit, I don't know what the right word is, jealous, because when ACOG made their recommendation in 2015, the American College of Obstetrics and Gynaecology officially recommended opportunistic salpingectomy in 2015, and uptake really took off like quite dramatically at the time of hysterectomy. So it is being done quite regularly at the time of hysterectomy in the US. The issue in the US is that we don't have great data to understand how often it's happening at the time of tubal sterilization, because it's easy to measure at hysterectomy because hysterectomy is an inpatient procedure. So we can see that happening in the inpatient data. But because tubal sterilization occurs usually as a day surgery, as an outpatient procedure, it's very tricky to understand how often it's happening. Some organizations have done chart reviews and found that it's happening a lot more often than the official data would tell you that it is. So people are often sometimes coding tubal ligation because they don't really know how to code it as a salpingectomy, but they're doing a salpingectomy instead. So I know that there's work in the US to sort of make some changes to the way that the data are collected so that we can get a better sense of how common it's happening at tubal sterilization in the in the US. Because I think the tubal sterilization people they're going to get like the most benefit from this, because there's not going to have been time for any lesions to have developed in the fallopian tube. We know, like, once a lesion has developed, if that seeds into the peritoneal cavity, that person can get a cancer many years after those fallopian tubes were removed. So the earlier we get the tubes out, the more protective it's going to be. And we think it'll probably be quite protective against endometrioid and clear cell cancers when it's done in young women as well, because the fallopian tubes in those cases act as the way that the uterine tissue gets to the ovary. And for endometrioid and clear cell cancers, it's uterine tissue that is the tissue of origin. So if we remove those tubes at a young age, we think we'll probably prevent a lot of those as well.
Great. Right, thank you. Do you think polycystic ovarian syndrome will be considered a lifetime risk for ovarian cancer?
The data has been a bit unclear around PCOS. And if it does increase lifetime risk for ovarian cancer, it doesn't do it very significantly. So it's not something that is currently factored in a lot of these risk algorithms because it doesn't seem to be a really important driver.
Okay, thanks. I'm just going to skip to one question because it's a clarification, and then we'll come back to the other ones. Are you saying that tubal sterilization is the removal of tubes?
Tubal sterilization is anybody who says, I don't want to have a future pregnancy. Can you do something to my fallopian tubes to prevent me from having a future pregnancy? So that used to be a ligation. So we would just cauterize. Like, I'm not sure, it might take me too long to get back, but I did have a picture at the very beginning of what that actually looks like. Here, let me see. So this is like, we would just block them, right? We would cauterize them to prevent the egg from getting from the ovary to the uterus, or sperm getting up here to get to the egg, right? So, but we would leave all of the tissue in situ. We would just cauterize here. And so what we're recommending now is this, which is to take these tubes and take them out entirely, every single last bit of them. And so that's still tubal sterilization, but it's tubal sterilization done in a different way. So instead of ligating, what we're saying is remove completely.
Okay. All right. How does removing the fallopian tubes impact a woman's health other than preventing cancer?
we have no evidence that it does at all. So that's a lot of the work that we've been doing the last 10 years, is just to say, like, are we absolutely certain that this is safe? And everything that we have looked at has come back saying it appears to be completely safe. There is some question. So when we first surveyed OBGYNs about this, like back before we made the recommendation in 2010, to say, what are your concerns? They said, is it possible that the fallopian tubes, although they're not part of the ovary and they're not part of hormone production, if we remove it, could we somehow disrupt blood flow to the ovary and change that hormone production so that that woman goes into menopause earlier, which we don't want to do. We don't want to put anyone into menopause earlier, because earlier onset of menopause does have health implications. But all of the work that's been done to date has not shown any indication that hormone production is influenced by the removal of the fallopian tubes. So there's been randomized controlled trials that have looked at hormone markers before and after in groups who had hysterectomy alone and hysterectomy with salpingectomy, and they found no difference in any of the hormone levels. We looked at this using our data to look at whether there was a difference in time to starting hormone replacement therapy and time to a physician visit for a menopause-related concern. So we compared those groups, and there was no difference. But I think that it's fair to say that the question is not entirely put to rest yet, because what we really want to see is a study that's powered on actual age of onset of menopause, which the only way to measure that properly is to ask a person whether it's been 12 months since their last menstrual period. And so there is a randomized control trial in Sweden where they may be able to finally put an end to any concern around the hormone issue by doing that analysis in the people who were part of that trial. So nobody who's looked at this literature expects to see a difference, because everything that's been done to date has been very reassuring. But hopefully that will be sort of the nail in that coffin.
And, I know you mentioned earlier ACOG, I believe you said in 2016 had already recommended this here in the States. And I think Society for Gynecologic Oncology has as well. So
yes,
obviously
2013 for them, they were 2013. Earlier. Yeah.
Okay, so we will get long-term data, but I think the fact that they recommended it, both of them must,
yes,
the good outweighs the harm, I think.
There are 9 countries now worldwide that officially have recommendations for opportunistic salpingectomy. So yeah, it's there are many different societies around the world that have said that the evidence is convincing to them in terms of the safety and the risk reduction.
Thanks. Okay, so Diana asked, if cancer starts in fallopian tubes, why is pregnancy a preventative? You ovulate whether the egg becomes a baby or not.
Yeah, so this is a very good question. And we think that the etiology is through inflammation in that fimbriated end. So every time you ovulate, there's actually a lot of inflammatory factors that go to this fimbriated end of the fallopian tube. So when it's doing its job and sort of attaching to the ovary, and it becomes very inflamed. And as you may be aware, inflammation in general is a risk factor for DNA changes, which is the way that most cancers start. So that's the hypothesis, is that, part of the reason why everybody thought for so long that ovarian cancer arose on the ovarian surface was because of this clear link with number of ovulatory cycles. So you've picked up on a very significant, confusing issue that was troublesome for the medical community for a long time too, is, well, if it's ovulation, it must be each time the ovarian surface ruptures. But it doesn't look like that's the case. We're very convinced now that the fallopian tube is the tissue of origin for the vast majority of these serous cancers. And so we think that the mechanism is through all of that inflammation that occurs with each ovulatory cycle. So if you don't ovulate, you don't have that big inflammatory burst.
Thank you. All right, Diana, that was a good question, Diana. Thank you. All right, so Linda asked, I told my sister about this before a surgery she underwent this summer, and she was able to convince her surgeons to do this. The surgeon was concerned about it being covered by insurance, so they didn't list it as scheduled before the surgery. Is insurance typically an issue? And I know our systems are different, obviously, from the British Columbia, but maybe you have some insight.
It is, yeah, it is. But there are people who are really working on this and trying to push forward with this, because it's less of an issue during a routine gynecologic surgery, because OBGYNs would regularly bill for a salpingectomy, and are expected to be doing these types of operations. It becomes much more of an issue when you are talking about doing it in other surgeries like colorectal surgeries and cholecystectomies and other routine like chronic appendicitis appendectomies, things like that, because those surgeons are not really supposed to be removing fallopian tubes. It also is apparently an issue with Medicaid. So if you're having tubal sterilization and your insurance is Medicaid, it can be tricky to change it to a salpingectomy rather than a ligation. But there are people in the US who are working on this and are tirelessly trying to change a lot of that. And some of it is just really dull things like not having the correct code to write down and to bill for. So, even something like that, like you have to go to the CDC and request new codes. And that is a process that, bureaucracy doesn't always move as quickly as we would like, but that is all underway. So there's a lot of efforts to try to remove a lot of these barriers.
Right. Well, I know it's something we intend to work on OCRAs too as well. And, we'll just keep plugging away at it. I think a recommendation would be to talk, and Gillian, tell me if you think I'm wrong, but I think talk to your doctor about it and see if they have any insight, if they've done this before, if they have any thoughts on billing, and then obviously talk to your insurance company if that's a concern before surgery. I think that's important. Okay, Gary Weeks. Hello, Gary Weeks. What is the plan to distribute this information to OBGYN docs? Well, I can answer the beginning of that, Gillian. You might have some more to add as well. But we worked very closely with Gillian and her team and a number of other people, we being OCRA, beginning of the year. And some of you may know and some may not, but we got a lot of placement in media with this messaging that we're talking about today, about prevention and about early detection and symptom awareness and genetics and knowing your risk. We run the front page of the New York Times, Washington Post. And so I've joked many times that I'm glad to finally be, in for science as opposed to like a celebrity or something else. So we are really thrilled with that. We hope that we're helping you as an organization spread the word, Gillian, because even though it's been adopted by these two medical societies, it's still not done everywhere. It seems like it would be in the United States, but it's not.
Yeah, no, the knowledge translation efforts that you and your team undertook were incredible. If I've given 20 media interviews about opportunistic salpingectomy in my life, 16 of them were after your recommendation. So, there was just a lot of interest and a lot of awareness building. And that was fantastic. We just had all of a sudden so many more eyeballs on salpingectomy. And, I had lots of OBGYNs reaching out to me to ask more questions and to say, oh, I didn't even realize this was something I should be doing. And so, yeah, no, your efforts have been very instrumental.
Well, great. We're happy to help. And we'll continue to do that as well. Okay, so we have a question from Patricia. I had primary peritoneal cancer. On pathology, the no cancer was found in the ovaries or in the fallopian tubes. But since I had a BRCA2 gene and my sister had the same gene, she had her tubes and ovaries removed. But if I didn't have any cancer in the ovaries or tubes, how does this protect my sister from primary peritoneal like I have?
Because most primary peritoneal cancers begin as a stick in the fallopian tube, and some of those cells manage to shed, and then the cancer grows in the peritoneum instead. And this can happen, quite a while before. So I presented data that there were 0 serous cancers in our opportunistic salpingectomy group to the end of that study, but we have now since found one, and it was because there was a stick lesion in the fallopian tube at the time that that patient had their salpingectomy. So they already had that initial beginning of a cancer, and that had shed and found its way to the ovary and began to grow as a cancer, but it can find its way in the peritoneum as well and grow there as well. But if your sister has had her fallopian tubes and her ovaries removed, the tissue of origin where that initial lesion would start has been removed. So now the opportunity for that stick lesion to develop is no longer there. So she will still be protected.
And when fallopian tubes are removed, are they always analyzed to see if there's any precancer risks?
Not unless the patient is high risk.
Okay.
So in the BRCA 1 and 2 patients, when the fallopian tubes are removed, they do CFIM protocol, which is very carefully sectioning and looking for stick lesions because they want to make sure that they've removed a healthy fallopian tube. We do not do that in the general population because it's not, you just don't find enough stick lesions to make it worthwhile. It's very intensive work for the pathologist. It takes a lot of time and energy and effort for the pathologist, and it's not worth it in the general population because usually those are healthy, low-risk tubes. So that person in BC who developed a cancer after the salpingectomy, the only reason that we knew that there was a stick lesion in the tubes at the time is that after the cancer developed, we went back and got them and sectioned them and found it.
Okay, got it. Okay, this is probably the last question, but so does primary peritoneal begin in the fallopian tubes as well? Jenny asked.
Probably.
Yeah.
I mean, there's a lot that we still don't entirely understand about the etiology and the biological mechanisms underpinning high-grade serous ovarian cancer. And so, we also have some work that we're collaborating with OCRA on to better understand that, because the more we can understand how these things start, the better we're going to be at preventing them and making sure that we're keeping people alive. So we're trying all the time to better understand how this works, but the best answer I have for you right now is probably.
Well, Dr. Hanley, thank you for all your work and for all your help and for doing this lovely presentation today. We had a lot of great questions. I think you got to make every question sort of provided you with a different nuance, I think, to address, right? But you had all the answers, so thank you.
Very, very thoughtful questions. So thank you, everyone.
So thank you to the engaged audience and for all of you for joining us. And I hope you have a great rest of today and you enjoy the sessions. And then I'll see you on the end in a couple of days. All right. So take care. Dr. Hanley, thank you so much.
Thank you very much for having me.